It's a great privilege to be here to give you this talk on endoscopic tympanoplasty, and I'm very grateful to Gaurav and the organisation team for allowing me this opportunity. My name is Bav. I'm a consultant ENT surgeon working at Northwick Park Hospital and also have affiliations with these other institutions. I'd like to start by taking a contrarian view and saying that tympanoplasty arguably is more difficult than stapes surgery. And why do I say this? Is it because I'm a poor surgeon? Perhaps, hopefully not. But if you look at the documented outcomes from tympanoplasty in the literature, the success rates are documented as between 65 to 95%, which is significantly poorer than that with stapes surgery, which is between 90 to 95%. And if I compare this to my own data, over the period of my time as a surgeon, as a consultant, I've had an 85% success rate, and in the last 12 months this is better, it's around 93%. But this is significantly less than my stapes results, which are 95% over the entirety of my practice, or 96% over the last 12 months. So why are my tympanoplasty rates poorer than stapes surgery? I would argue that this is because there's three different considerations when considering how difficult or easy an operation is. These are the cognitive, the psychomotor, and the judgment aspects of surgery. The cognitive aspects relate to understanding the surgical steps, the anatomy of the surgical field, and understanding which steps can be done quickly or slowly. The psychomotor aspects are the haptic skills and the motor skills required to perform the surgery successfully. And I think stapes surgery obviously is more difficult than tympanoplasty from a psychomotor perspective. But in contrast, I think in the last domain, judgment, I think tympanoplasty is harder to learn. And judgment relates to understanding how different operations can vary and what the implications are of different variations in terms of the surgical technique and how the technique should be adjusted to achieve the objectives. Tympanoplasty, in contrast to stapes surgery, can be different with every operation, and although the objectives are typically the same, i.e. to close the hole may be found in different locations, the middle ear status may be different, the requirements of the surgeon may be different according to the operation, and these all require subtle changes and adjustments which significantly impact the success or failure of the operation. And I think judgment is a lot harder to master than the psychomotor or cognitive aspects of surgery. And this is probably why in the learning curve, when you first start off, the success rates tend to be lower. And as you gain experience and surgical judgment, your numbers improve. And that's been my personal experience, certainly as a consultant. So in tympanoplasty, one size does not fit all, and there's a number of different considerations that we should all be aware of as surgeons that should inform our choice of surgical technique. The first is the etiology, what's caused the perforation, whether this is a simple traumatic perforation or whether this is a sequela of chronic otitis media and that spectrum of disease. The second thing to consider is the current middle ear status, whether there's active inflammation or whether this is a quiescent ear, and these will have implications on what you do. Equally important is the location of the perforation in terms of whether this is central or peripheral, and we'll discuss the implications of this on your technique. You should also consider the size of the perforation and how this informs what graft material you should be taking and the approach to surgery. And finally, the patient-related factors. So patients may express certain preferences, they may have certain comorbidities that preclude certain types of interventions. And so your technique as a surgeon needs to be tailored to the patient's requirements also. So to start with, discussing etiology. So here are two perforations. On the left, you can see a very friendly traumatic perforation, which should be quite easy and enjoyable to repair. Whereas on the right, you see a patient with active chronic mucosal otitis media with a big perforation, subtotal perforation, and lots of middle ear granulations and polyps coming out through this perforation. Now, clearly, although both operations require tympanoplasty, the difficulty and the decision making for each of these is going to be radically different. And whereas on the left, you could do this under local anesthetic, you could do this in the outpatient department. On the right, this clearly requires a more involved procedure, probably under general anesthetic with a mastoidectomy, as well as a tympanoplasty. So a traumatic perforation typically does not have any associated middle ear pressure dysregulation, whereas those arising from chronic otitis media typically have suboptimal pressure homeostasis, which will require specific consideration in your choice of treatment and intervention. A thorough understanding of middle ear pressure homeostasis is important. Now, this is a video which you can find on YouTube, and it outlines the different mechanisms of middle ear pressure homeostasis. But essentially, it's important to understand and appreciate that there's three main mechanisms of pressure homeostasis, and they all serve different functions, and dysregulation of these mechanisms can result in ear pathology. So the first and most important method is the mucosal gas exchange mechanism. So while the middle ear and mesotympanum is lined by pseudo-stratified columnar epithelium, similar to that's found in the sinuses, with lots of goblet cells, the function of this compartment is to clear pathogens from the middle ear space and down the eustachian tube. That's why you have mucoid effusions that typically arise from this area, with goblet cell hyperplasia and excessive mucus production, which drives a certain type of middle ear effusion. The epitympanic and apical mastoid spaces are lined by respiratory epithelium, similar to what is found within the alveoli. And these are single-celled, so the purpose of this is to correct any subtle fluctuations in partial pressures of these gases, and gas exchange occurs in both directions across a concentration gradient. And this allows the ear to regulate subtle changes in pressure across a small band of pressure changes. And if you think about, as humans, we typically don't experience large changes in baro pressure because we typically tend to be evolutionarily within a certain narrow range of baro pressures. So we typically don't need to experience or equilibrate large fluctuations, for example, from going deep underwater or high in the sky, like a bird or a fish might need to. The second mechanism is the eustachian tube, and the purpose of this is to release excessive middle ear pressure, or to equilibrate these pressures, which can either be negative or positive. Typically, its main function is to release excessive positive middle ear pressure. We typically use this for Valsalva maneuver when on a plane, or when equilibrating when diving and ascending from a scuba dive. And the purpose of this is to equilibrate large fluctuations of pressure which are beyond the scope of the mastoid air cell system. The third mechanism is the mastoid buffer. Boyle's law states that within a smaller volume or a small compartment, changes in the volume of gas or amount of a specific gas particle will have a greater impact on the pressure within that compartment than if you have a larger compartment. So the mastoid, the attic and antral spaces are in continuity with the middle ear space and the eustachian tube through the anterior and posterior isthmus. These are spaces found between the malleus and the incus, and between the incus and the posterior canal wall. And these are two communications through which these two spaces are in continuity. Now, if those spaces become blocked, for example, by inflammatory webs or mucosal bands, then this will dissociate the tubotympanic from the atticomastoid spaces. And that means pressure changes within the tubotympanic space will be more acutely felt, and fluctuations will be more significant than if you had the mastoid in continuity, which would increase the volume, the effective volume of the middle ear space. If you have a patient with chronic otitis media and you're elevating the tympanic membrane, it's worth checking the anterior and posterior isthmus with your endoscope and opening these spaces if they're blocked, because more often than not, you will find some issue that's obstructing the communication between the atticomastroid and the tubotympanic spaces, and this is most frequently found either in the anterior and posterior isthmus, or this may be found in the antrum, which would need to be addressed with a cortical mastodectomy. The next thing I want to discuss is the location of the perforation, and to do that I'm going to switch to a different video. Looking at the tympanic membrane from a cross-section, we can see that it's conical in shape. This carries important implications in how we repair perforations at different parts of the eardrum. After applied to the peripheral drum, it is more easily able to align to the natural contours of the tympanic membrane, whereas more central located perforations can be challenging, particularly where they involve the malleus. If the drum is not separated from the malleus, the graft will need to bunch in order to follow the natural contour of the tympanic membrane. And this is even more challenging where rigid graft materials such as cartilage is used in addition to temporalis or perichondrium. The rigid material can't follow the natural contour of the tympanic membrane, and so the apposition between the soft graft and the drum may be compromised, increasing the likelihood of a residual perforation at the margins of the repair. As such, for very central perforations involving the malleus, it's important to separate the drum from the malleus at the umbo. The graft can then be placed between the malleus and the medial surface of the tympanic membrane, allowing the graft to sit in a more favourable position that will maximise the chance of successful repair. So as we can see, the location of the perforation has implications in terms of what graft material you use, whether you separate the malleus from the tympanic membrane or not. In my own practice, I tended not to use middle ear packing because I want to ensure that the middle ear ventilation is optimized, and I worry about the impact of packing on resulting in adhesions and mucosal thickening, which may subsequently block off the ventilation spaces, which are so important. The size of the perforation is also an important consideration when determining which technique to use. Very small pinpoint perforations can be closed with a fat plug by freshening the margins. If they're larger, you could use a poke-through technique using a soft graft such as Biodesign or perichondrium after filling the ear with packing material. For larger still, you could use a cartilage butterfly technique which bridges the margins of the perforation. Beyond this, you'd want to consider underlay techniques such as a soft graft such as perichondrium or temporalis fascia to lay underneath the margins of the perforation circumferentially. And as they get bigger, you'd want to combine this with a rigid graft, perhaps cartilage, which sits on top of the malleus typically. For very large or subturtle perforations, an interlay technique tends to work very effectively and should be considered. Finally, it's important to consider patient preferences, and you can perform tympanoplasty under general anesthetic or under local anesthetic with sedation. I typically tend to favour local anesthetic with sedation because it allows a faster turnaround, it allows the patient to recover more quickly, and it allows you to provide an on-table assessment of hearing if relevant for the patient, although typically not so relevant for tympanoplasty. Again, with tympanoplasty, you can perform this with an endoscope or with a microscope. I typically tend to perform my tympanoplasties endoscopically for anything transcanal and within the middle ear space. I will use a microscope or I will use an open approach if I'm performing a mastodectomy in addition to the tympanoplasty alone. Now, considering otology as a whole, I think tympanoplasty is very well suited to the endoscopic approach because the endoscope allows you to repair almost any tympanic membrane perforation using an endoscope transcanal without needing to make any endaral or post-auricular incisions. I think this is a great benefit for patients because it reduces morbidity, it reduces the recovery time and pain, while not compromising on the view that you achieve and allowing you to achieve a superior view which will enable significant confidence in your repair and reconstruction of the eardrum. Moreover, the endoscope allows you to address these pathologies within the outpatient or clinic setting. So we have had some success with patients who have undergone tympanoplasty in the outpatient setting. And here's a video showing you an example of what this looks like. My setup involves two different sterile trolleys, one with middle ear instruments and the other with general instruments. The middle ear instruments required include a round knife, a Hughes and Beals elevator, a curved needle, a 0.5mm Shambo hook, micro scissors, and cupped forceps. I'll also have a malleus head nipper available in case required, along with curettes of different sizes. The other set will include general instruments, including swab holders for sterilizing the ear, a small scalpel, 15 blade, iris scissors, a needle holder, toothed and non-toothed forceps, along with skin hooks. The local anesthetic is 1% Lignospan administered with a dental syringe and needle. Ordinarily, the patient will be faced away from me with a circulating nurse available to provide equipment as needed, along with a sterile assistant next to me in order to hold different instruments and the suction as required. The patient is under pure local anesthetic and has no sedation and is able to follow the operation on screen by watching the stack system. I begin by sterilizing the ear and examining the ear. In this case, you can see a nice quiescent ear. The middle ear appearances are clean. There is some tympanosclerosis, but the perforation itself is clean and dry, around 40%, but it does slightly abut the umbo in this patient. I begin by administrating local anesthetic with the Lignospan. This includes one infiltration behind the ear and one at the posterior superior quadrant of the ear canal, gently infiltrating until we can see blanching of the stria maliaris. In this situation, you see the local anesthetic is administered slightly too quickly, resulting in some swelling of the medial ear canal, although this will resolve itself within a few moments. I then proceed to freshening the margins of the tympanic membrane using the 0.5mm hook. In this patient, we have some tympanosclerosis posteriorly, but ideally we want to induce some bleeding, which will stimulate neovascularization. The tympanomeatal flap is fashioned in a bucket handle approach. This involves starting the incision very close to the annulus inferiorly and then sweeping laterally and moving more laterally as we get to the posterior superior quadrant before moving more medially superiorly, forming a bucket handle. For the outpatient technique, I use gel foam to soak up any blood. I do not use cotton wool or adrenaline in the outpatient setting, although I typically would use this in theatres. I'll then elevate the flap using a round knife, gently and sequentially elevating medially. Sometimes the posterior superior skin is thicker and requires the micro scissors in order to divide the skin. Once underneath the annulus, we can then raise this either with a D knife or a Beals in order to enter the middle ear space, which we can see here, which is nice and clean. We have a fantastic view here of the long process of the incus, the stapedius tendon and the pyramid, along with the stapes. Here we can see the entire margin of the perforation as we look underneath our flap, and then we continue to elevate the flap in order to improve our access. So here we can see a band between the malleus and the incus, which is a band of adhesions, which is obliterating the anterior isthmus. This is removed in order to improve mobility and ventilation. And this is separated with a curved needle. While doing this, I can feel that the malleus is very fixed and not mobile, which probably is contributing to a significant conductive loss in this patient. I will then separate the tympanic membrane off the malleus, given that the perforation is so closely adjacent to the malleus. I'll then proceed to stripping the malleus handle and removing the skin from this, usually starting more superiorly where the plane is more easily and readily identifiable before progressing more inferiorly towards the umbo. Once this is achieved, we can be confident that we've got good exposure. Within the theatre environment, using a laser to remove any residual squamous epithelium on the umbo can be useful. However, in the outpatient department, I use a malleus head nipper just to remove this. And because the malleus is so fixed, we can be confident that this won't be transmitted towards the ossicular chain into the stapes. So once elevated, we reposit the flap, and we can see that the flap is nicely elevated and free of the malleus and sitting in a more physiological position. Given the fact that I know the lateral chain is fixed, I then separate the incus from the stapes in order to palpate the incus and the malleus and to assess the degree of lateral chain fixation. And in this case, we can see as I palpate the malleus, there's little movement of the incus. I'll then gently traction the long process of the incus to try and see if this will free up the mobility somewhat. And once we've done this, we can see that palpating the malleus transmits movement more effectively to the incus. And then I'll reposit the incus back onto the head of the stapes. Once I've harvested some tragal cartilage, I'll then lay this on top of the bared malleus. This provides two functions. Firstly, it maintains the middle ear depth and uses the malleus as an anchor upon which this cartilage can sit, and we can be confident that it will not then move. And it then serves as a bed upon which I can apply my soft graft, which is the perichondrium. This is delivered and placed onto the undersurface of the drum. I like to oppose this to the undersurface using a Heels or Beals dissector to press this against the undersurface. And ordinarily, where the undersurface is moist, the perichondrium will stick to the undersurface quite readily with surface tension and then will not move. Once we reposit the flap, we can see that the soft tissue graft is sitting nicely, closing the perforation circumferentially. I'll then pack the ear with gel foam. This can be soaked in PRP, platelet-rich plasma, or it can just be applied on its own, and then gently ensure that the gel foams are sitting on the periphery of the perforation all the way around, and then continue to apply gel foam to the remainder of the drum and over the tympanomeatal flap edges in order to keep this in place. The entire canal does not need to be filled with gel foam, but I'll place gel foams in order to keep the tympanomeatal flap in its appropriate position. These remain in situ for 3 weeks, and then covered with ciprofloxacin drops. 3 weeks later, we can see healing appearances of the tympanic membrane with good apposition of the drum, and we can see an improvement from preoperative hearing to an improved appearance post-op. The patient reports an improvement in their own hearing as per their feedback, and this is a good result. So this slide demonstrates different examples of different types of tympanoplasty and the relative pros and cons of each type. Now, there's no single best approach to tympanoplasty, and it all depends upon what you're looking to maximize and which areas you're willing to compromise upon. So you could think of the best approach as being one that guarantees or offers the highest rates of success. It could be one which you can do in the shortest period of time, one that provides a very robust repair that is unlikely to reperforate or re-retract. You could be wanting to prioritize the hearing outcome for the patient. A patient may have significant comorbidities that makes you want to do this in the outpatient setting or awake, and certain techniques will lend themselves more readily to an outpatient or awake technique. You may prefer those which are easiest to perform or easiest to teach, specifically if you've got a junior colleague who you're wanting to train and they're just starting out and you want to offer them an operation that is easier for them to do. Finally, different techniques can be used for a variety of different perforations. So while a butterfly technique is excellent for its success and its ability to do this awake and providing a robust repair, it cannot be used in every type of perforation. For example, those which are sitting adjacent to the malleus or at the very periphery are not suitable for a butterfly. Whereas by contrast, the interlaced tympanoplasty can be used for a variety of different perforations even subtotal or large perforations, but take longer, are not so suitable for an outpatient or awake technique, and are technically more difficult to perform. So the purpose of this slide is just to demonstrate that there's not one single technique that is most useful or necessarily a single best technique. Rather, there's lots of different techniques which each have their pros and cons, and the surgeon should consider which technique they want to employ for the specific case at hand. So to summarize, there are many different techniques for performing tympanoplasty and many different decision points that a surgeon must consider before listing their patient for surgery. These are influenced by a variety of factors, including the size, location and extent of the perforation, along with the middle ear status, along with the patient's preference and surgeon experience. Tympanoplasties are not a one-size-fits-all operation, and being familiar and understanding the relevant indications and contraindications of different techniques will help you to achieve the best results for your patients. I'd be grateful for any questions you might have, and if you did want to look at further materials, here are a few of my YouTube and social media handles, and I'd be happy to receive questions via email or through my website. Thanks very much, and I look forward to catching up with you again on Wednesday for the live surgery.